we are very much about legacy, tradition, and I always like to put up, a slide that basically just has the people that influenced me during my era at Penn. So we're lucky enough not to have only the traditional legacy Penn people, but we had also some people like Frank Salenza that used to come down from New York to teach us. And we also had the Scandinavian school that was actually, we were lucky enough to come with them through the years that I was at Penn. So this is typically what we do. So traditionally what we do is just deal with the treatment of patients who suffer the ravages of periodontal disease. So these are very, very difficult situations to restore because, as you can see, it's not only a matter of having to deal with the white tissues. The pink tissues are involved, meaning both soft and hard tissues, bone, gingiva, et cetera, and these are very, very difficult situations to treat, particularly with implant therapy, because as you well know, the framework for those reconstructions is going to be the gingival tissue or the peri-implant soft tissue architecture. So now with the advent of all these new paradigms in dentistry, where implants are ubiquitous, everyone's doing them, and more people will continue to be joining the implant field. We have the advent also of aesthetics, where now it is part of the criteria for success of the restoration, and you have also the patient who's also voicing their opinion. You have now digital dentistry tools that are becoming now ubiquitous, and also the fact that I think the field, in large part to the efforts, thanks to the efforts of Dental XP, appreciates the impact that interdisciplinary therapy can have in terms of treating these complex cases. We have a complete different paradigm now. So are all these new tools in our armamentarium helpful when we have to come up with an answer for somebody like Kelly, for example, or a patient like Aisha, for example? What answers do we have to treat cases like this? So the topic of my presentation today is going to center on the treatment of the complex cases using interdisciplinary tools. You're going to see a lot of cases that have high smile lines because I believe that that's where you have the biggest challenges. I'm also going to be introducing a new concept that I've been working on for the last 3 years. The Salama brothers know this, Eddie as well, because I've been able to participate more with XP as a result of this. And you're going to have to give me a little bit of latitude here because it's going to be completely different than what you've been seeing so far. Okay? We'll get to it. So the issue with aesthetics in the implant field is that traditionally the literature has been focused mostly on success and failure rates. The aesthetic parameters being mostly underexposed in most clinical trials, and whenever we've had them, we had lack of objective or uniform criteria to actually judge those outcomes. This all changed with the publication of the now well-known Pink Aesthetic Score. And if you take a look now at all the parameters that comprise this Pink Aesthetic Score, it's all about soft tissue. So it gives you an idea that in reality, the most difficult part of actually attaining successful aesthetic outcomes around implants has to do a lot more with the pink tissues than it does with the white tissues. Now, for the sake of definition as to what is it that we're going to be talking today about, we are looking at outcomes where the implant-supported restoration will emerge from the soft tissue pretty much in the same way a natural tooth does or a tooth-supported restoration does. So that is what we're looking for today. Those are the goals for our presentation today. So the first question I would like to pose to you is whether or not there are certain specific clinical scenarios that are more conducive than others to predictable implant aesthetics. And this has been addressed a few years ago during a consensus conference by Belser and coworkers. They identified that in the literature at the time, these 4 particular scenarios have been published, of which the only one that resulted in consistent, predictable aesthetic outcomes was the single tooth type of scenario. So if a patient presents to your office for treatment of a single tooth, there are a couple options. If the patient presents without the tooth, then your options are basically limited to regeneration and having a traditional or so-called delayed approach. However, if the patient presents with the tooth in place, then you have the alternative to perform an immediate implant placement and provisional as well. So immediate implant placement and provisionalization is a technique that has become very popular because of the fact that it's conservative, it's efficient, it results in decreased treatment duration, less expense and morbidity, while providing similar aesthetic results and predictable aesthetic results as a traditional technique, along with similar survival rates as well. Personally, as a result of the influence from the publications of Joe Kahn and Peter Worley, I've been doing this since 2004. We brought it to the university in 2007, and we subsequently developed a protocol that is featured at Dental XP, so we don't have to go into that much detail because you can actually review the video there. So basically, we utilize a flapless approach, well, a traumatic extraction. And I'm sorry, but a traumatic extraction should not involve a forceps. The way forceps beaks are designed as to apply pressure, they go apically. And the whole idea is to actually preserve as much as possible, particularly as it pertains to the buccal table. So you're talking now about a traumatic extractions, drilling then toward, I think I lost for a second there. Okay, drilling towards the lingual, and placing the implant in such a way that there's a gap that is 2 millimeters or more, and this gap is going to subsequently fill up to the level of the buccal, of the osseous crest, not beyond, with a xenograft. So if the insertion torque is 45 Newton centimeter or more, then we'll proceed with a immediate provisional as well. And there's a few ways to do this. And we can enter into a number of discussions having to do with how you should manage the contour. We basically use or follow a critical subcritical contour, whereas we basically just choose the ideal contour of the definitive restoration desired, and based on that, we determine the subcritical or subgingival area contour. So there are a couple of techniques to do this. One is a traditional technique where you start with a careful wax up, identifying all the margins that you desire in the restoration. You fabricate a provisional, you jump it into place. I like to place mine with some kind of device that will help me seating it. Either it's going to be some kind of jig or these wings. And then basically, after you pick up the temporary cylinder, develop your contours, cut off the wings, and then you can deliver the restoration. The other option is to utilize the patient's own tooth or a pre-existing restoration, and you can actually retrofit this. Again, I like to use some kind of device or jig that will help me with the seating of these restorations. So we go, in these cases, to the whole adhesive technique. We jump the case, and these work out fairly well. The only downside being that these are extremely durable restorations that the patients tend to walk away with them and then not come back for a while, as is the case with this patient. And you see, this one in particular is a very busy pediatrician in our local hospital system, so she doesn't make it back until she has some other unrelated problem. And now you see after 18 months, you can compare any changes, if any, from the pre-op photograph all the way on the left to the 18-month postoperative. So as part of the protocol, we have a very specific occlusal management perspective. And this is born out of the fact that we've had some issues, obviously. So if we're going to be placing an immediate provisional, we want that to be completely out of contact. And that means not just centric contacts, but also excursive contacts. So one of the ways of doing this is with an appliance. And you can see, if we look at an example of these cases, you have where facets present, you have deep bites. I mean, you need to provide the space to actually just have more biomechanical control of the loading of this immediately provisionalized implant. The only problem with these appliances is that you depend a lot on the patient's compliance. The patient may choose not to wear it, and at the end of the day, whether it's the patient's fault or your fault, if you need to replace the implant, it's not going to be a good scenario for anyone involved. So what we tend to do is to open the bite by adding composites to the occlusal surfaces. I like to have 3 stops bilaterally with bilateral contacts, and basically the patient will then have this situation during the time of osseointegration. You can help yourself by using perhaps a material that's of a different color so it can be removed more easily when the time comes. And this happens with, the orthodontists do this all the time to actually prevent bracket debonding and so forth. We do it routinely. On occasion, you get intrusion of a bicuspid. after you remove these stops, the teeth come back into occlusion in a matter of weeks. So due to a lot of the controversy having to do with publications from Linde, Araju, Stroke, Carteropoli, et cetera, having to do with whether or not you could actually place an implant immediately and keep the buccal plate, and because we're having these very good clinical results, we decided to just embark on a clinical trial where we would then try to figure out what was the fate of the buccal plate, pretty much using the same clinical parameters that we were using with our patients. And we did this at Penn, I think starting in 2010 or so. And what we found was that placing the lingual towards the lingual resulted basically in bone deposition along the entire gap between the implant surface and the buccal alveolar bone. The gap fill resulted in complete bone-to-implant contact, at least radiographically, and this was consistently observed. The thickness of the labial plate remained the same from 0 to 6 months, which is the duration of the study, except when very thin bone was present, and that would be in the order of 0.5 millimeters or less. We deducted that what was happening here was that the resorptive changes of the buccal plate could be a result of either trauma from the extraction process or from the implant placement. And that using a flapless technique, I'm going to go back. And that using a flapless technique may actually limit the resorption of the external aspect of the buccal plate, while placing the implant towards the lingual will then limit or prevent resorption of the internal aspect of the buccal plate. We presented this years ago. It was published, maybe a few years too late, 2-3 years too late. We presented in 2010, and Henry, we were having a conversation about being on the podium, being the only guy that talked about immediates when everyone was talking about stage. I had the same situation with Julie, actually. I don't know if Julie's here, with Danny Boozer. And I'm glad to see now that Danny appears to have come around. And you see this consensus type of paper where a lot of the specific parameters we basically just require to do our immediate cases, he recommends as well. So it can be technique sensitive. You need patient selection. I want to make it very clear that we only do these in intact sockets. We only do this in intact sockets. So my preference is to make sure that then we have the tools, and those will be interdisciplinary tools, to actually develop compromised sockets into ideal sockets. And we'll talk about this. So if immediate implant placement and provisionalization then is a gold standard in terms of achieving predictable per-implant soft tissue aesthetics, what do we do when we have sites that are not ideal, sites with defects? Is there any way of achieving predictability on these sites? What if the site encompasses several teeth? If you look at the literature, it is documented, I think fairly well, that if you have several adjacent teeth, a defect that encompasses several adjacent teeth, this is going to be a very difficult situation to manage aesthetically. So then the next question will be, how predictable are traditional surgical approaches with regards to yielding adequate or acceptable per-implant soft tissue aesthetics? And again, if we take a look at some of these cases, you see these have been grafted already. You can look at the results. And I will venture to say that this is something that we see more often than not. So I'm sure that many of you here do these kind of procedures, and when you see someone that's very good at what they do, such as Julie or Isvan doing it, and you see those results, they're amazing results. The question is one of predictability. And when you have a patient where the outcome is mission critical given the specific characteristics of the case, where can you go, where can most of us go to actually attain predictable outcomes? If you start looking at the literature, you'll see that there's a fairly good amount of evidence that's growing also that points towards the fact that there are issues when you have large reconstructions and GBRs. Advanced reconstructive surgery, especially GBR, increases the risk for complications and compromised aesthetics. Less favorable pink aesthetic outcomes in augmented sites. Flapless surgery contributes to better aesthetic outcomes. And then a recommendation that clinicians should limit papilla opening. So what if now you have a situation where you set yourself into a workflow where you need to do this procedure several times on the same site? Is this conducive to predictability? Tell me. Because I sit with my students in seminar every Friday, surgical seminar, and we see the results with the faculty as well. So it's really an issue of how predictable can you be? How can you prevent the exposure? How can you save the papillas? How can you get no recession every single time? And I'll tell you when you need it. When it's a high smile line patient, high-risk patient, meaning someone that already comes from another office or maybe two, where procedures have been done that have failed. What will you resort to achieve the best result? So what about pink? We do have alternatives that include pink restorations, and many situations it can work. But if the patient has a high smile line, it's very difficult, because it doesn't matter what you do. The patient is going to show a transition between the pink restorative material and the gingival tissue. And no degree of virtuoso laboratory ability, such as pink has, for example, is going to be enough to compensate for a prominent anterior display. Because at the end of the day, the success in these cases doesn't depend on you or the technician. It depends on the patient's anterior display. So if this is a case for the sites with defects, right? Are there any cases where we still utilize traditional surgical approaches, meaning elevating flaps, doing GBR, and or pink restorations? Yes, of course. It's not an absolute rule. There are cases where you have no other choice, like this one, for example. You just need to create the bone to place the implants. You need volume, and that's going to be achieved through traditional techniques. And after you achieve the volume, then you can go ahead and choose to place the implants, whether you want to do them freehand, or you want to do them guided, whether you want to just do it staged, or just go ahead and also do an immediate loading type of procedure, that's fine. So there's always going to be a certain number of cases. I would argue that, in most, at least in my private practice environment, they're not the majority of the cases, but those skills have to be present. You need to have that in your bag of tools in your armamentarium. So my timer went off. I have no idea what I'm doing here. 12 minutes? 20. Okay. So more and more, this is what we're doing. Jonathan gave a great presentation yesterday, and he showed an excellent example of why is it that we don't do acrylic anymore. Okay, regardless of the space that you provide. This is not a material that can survive opposing a natural dentition or opposing an implant restoration. So between complications and failures, the rate is about 91%. So we basically just go with monolithic zirconia whenever possible, and that will include a layer of feldspathic for the pink, sometimes a layer of feldspathic for the 6 anteriors or so. And in this case, for example, we can get away with it because of the patient's smile line, once again. So let's take this a little bit further. What if the patient has teeth? What if teeth are present? What if you have a situation like the one you see on the screen here? Teeth are still there. They have a poor prognosis. But if you extract them and you try to just reconstruct all this with traditional GBR means, what will you get? Won't you get a multi-tooth defect that is precisely the type that we just documented is so difficult to treat? So, do we have any tools that we can utilize to actually develop these compromised sites? And I'm going to show you an example of a case I treated several years ago. And this is a private practice case. You can see, I think it's self-explanatory, the appearance, some periodontal issues, high smile line as well. You have an idea here of the amount of attachment loss, some of the initial mobility, probing this as well. And you can see that there's going to be no papilla here, obviously, if you follow the fact that this doesn't meet anywhere near the requirements set up by Tarnow in terms of the 5 millimeter rule, for example. So in this case, what we decided to do is to go ahead, clean up remove the old restorations, make sure there's no caries, clean out the preparations, place individual crowns, temporary crowns that are cemented permanently. Then basically just set up the case for forced eruption. And I have to say, there's a long tradition of forced eruption at Penn. We all learned through, what Jeff Ingber did, what C. Brown did, what Henry continued to do, what Maurice continues to do, what David did. And it is a tool that for us is basically second nature. Okay, we always have it present in terms of being able to manage these cases. It's invaluable to manage these cases. And what would happen here is that as the wire straightens out, basically, of course, what happens is the teeth will move in the coronal direction. And in the presence of gingival health, what you're going to get then is basically a coronal migration of the attachment apparatus as well. And what will happen is that you actually will not get a change in architecture. The architecture pretty much is the same, except more now at a more coronal level. That allows you now to have sufficient tissue so you may go back now and have a plastic revision of the gingival margin that will allow you to re-establish the papillas, as Henry has demonstrated many, many years ago. And when we do these complex cases, I think it's something that we're forgetting a lot about, there has to be a reevaluation period. Post-orthodontic, we always have these cases stable for 3 months. Why? Because they have to settle, there's a mineralization process, and this is not just a fly-by-night type of number. It is documented in the literature in terms of being able to actually observe the changes in radiopacity. So at 3 months, you see basically that probe is at about less than 2 millimeters and there's blanching. So clearly there's something attached in here. And you may actually compare this with what we had before, and you see there's a substantial improvement. No doubt some of it came from shrinkage of the tissue due to infection control, but it's still a substantial improvement. So what do we have now? We basically have now a situation where you go from basically an 8 millimeter probing depth on the mesial of that lateral to maybe 2 millimeters, okay? And because we're comfortable handling these kind of cases, I'll say, okay, so I can live maintaining the right lateral, the centrals. Maybe the left lateral is getting a little bit too guarded. But now you have a situation where instead of having that tooth with an 8 millimeter probing depth on the mesial and 2+ mobility, you have now a probing depth of less than 2 millimeters. Now, whereas many of us in this room may consider extracting that tooth, here on this side, few of us would think about extracting it. If you chose to extract it, what you have now, though, is that you have now converted this scenario into a single tooth site with an ideal alveolus, precisely the one that's going to be the most predictable in terms of peri-implant soft tissue aesthetic outcomes. In this case, we decided to just keep the teeth, restore them, and this is the beauty that you actually get when you restore these teeth. When you keep the teeth, you get this unbelievable harmony between your restorative margins and the gingival margins. And you can see here the changes also in terms of the radiographic appearance and the crown through ratio and so forth. Now well within the Tarnow numbers. So this technique can be utilized also to basically develop sites where the teeth are basically terminal. And again, to paraphrase Henry, hopeless teeth are not useless teeth. And we're using here these hopeless teeth to develop the sites so we can now have, once again, intact sockets. So these are immediate implant placement into the intact sockets, which are really the most predictable situation for any of us here. So we go ahead and we provisionalize the day of implant placement, manage the occlusion as we talked about, and then the case is subsequently completed following our rules with critical and subcritical contour. And again, if you're interested, I'll point you in the direction of those articles, but we just don't have the time to discuss this any further today. So let's take this concept now to another level. Okay, so this patient now presents, and you can see he's referred by a periodontist, she's been treated by an orthodontist. They cannot move the left central, it's ankylosed, history of trauma, et cetera, et cetera. Some endodontic therapy, who knows? So what we're going to do in this case is use pretty much the same principles, because what we have here is really an intact alveolar housing, except that it's in the wrong position. It's apical. So we're going to basically just raise a flap here, and it's a full thickness flap. We're respecting the papilla, and I'll explain why in a second. So we have access now. Okay, we basically just kept the papilla, and now we're going to take a piezotome and go all the way to the palate. So this is not a corticotomy. This is a small block of osteotomy. And the angle you see here towards the left is because we're trying to avoid the nasal spine. So we're basically just trying to luxate the entire bony segment, including the root of the tooth. If you take a look at the width of the incisions, for example, you see that now it's getting a little bit wider, and that's because that's where we actually place the chisel and luxate to cause green stick fractures to develop through in the proximal crest without having to raise the flap. So we're going to graft. You don't have to graft the incisions. We're grafting to gain volume so we can subsequently go back in there and place an implant. But in the process now, after some soft tissue healing, we start the distraction. Now, this is my first case. So I thought, great, the patient has orthodontic appliances, I can use them to distract. No, that palatal flap takes a lot more tension than you would imagine. And what ends up happening is that you actually end up distorting the other teeth because there's forces placed on the rest of the arch wire. So this should typically be managed with some mini screws or things of that nature. But we eventually get them in the right position, and now they become like any other case. This becomes not like any other case. You can see we gain volume for the placement of the implant as a result of the grafting. And now with these cases, they're ankylosed, so I'm going to choose to remove the coronal portion of it, and I didn't do a partial extraction here or a shield. There are other cases where I've done it, but here we didn't. We actually now place the implant, and all we're doing here is, again, transferring the existing contour into the provisional restoration, which we will subsequently place. So here you have now the appearance pre-op, after the distraction, and then with the implant and the immediate loading. This was not the right patient in terms of selection. She disappears, has an argument with the orthodontist. She fights with everybody, shows up again. It's 4 years, and it's still there working as a temp. Okay? So let's now take this, 5, 10, okay, good. Let's take this to the next level. All right? This is school patient. Patient presents to us, you can see the issues. Open bite, a whole syndrome, altered passive eruption, mouth breather. So this is clearly an orthodontic case. And now there is subject to a full orthodontic workup. Finally, the case actually comes to us because the patient rejects this treatment plan. I says, I'm not going to do this. And I also have a limitation in time because I'm joining the Pennsylvania State Police, and I have to actually, in 6 months, and I need to join it without any braces. That's when the case comes to us, and what we're going to do now is now take advantage of our experience with some of the distraction cases to basically just distract the anterior segment. And we can do this because otherwise the patient other than this area, the patient has arch integrity. That's the reason why we can actually try this approach. So it involves moving the segment in two vectors, something that at the time was not possible with the traditional distractors. And again, this is the arch integrity. I'm having issues with this remote. Okay, so we actually make sure that we go over the epices. The teeth have root canal therapy, the 2 centrals. That was just caries driven when the patient actually got to us. So we go over the apices. And this video is the reason why neither one of my kids want to go into dentistry. So you need to basically just make sure that that segment is completely luxated, and you only there's nothing binding, and you basically just have the palatal flap that remains attached. Then in this particular case, we designed some customized distraction devices to go ahead with the distraction of this case. Again, now we saw mini screws and so forth. And now you see the crown lengthening is done. This is a case that we're preparing for a presentation to a tri-school event that we have with BU and NYU. So the residents are kind of pushing me. So a few weeks after the aesthetic crown lengthening, we go ahead and do a PMMA temp and so forth. and then the case actually goes to completion. So we have before and after. Okay? And one surprising thing here is actually the change in the nasolabial angle. I wasn't expecting that. What I should have. I thought I would have more gingival display, but I actually had less because of the drape. And again, let's take a look at the procedures, because I mean, this is what the patient had. Okay, these are the procedures. So I want to now show you what I've been working on, and I'm going to show this case to illustrate it. So Aisha presents to me after being treated by some local oral surgeons, and this is what happened to her. An implant failed, other attempts failed, it was grafted again several times, and now the parents say, you know what, let's take a step back. She's in college, let's take a step back, let's take a look at maybe we should just go in a different direction. So she basically comes to see me, and this is the defect she presents. You can see the severity of it. The canine and the central are basically don't have a good prognosis. So what are we going to do in this case? Should I do bone grafting? Should I do GBR, forced eruption, destruction of osteogenesis? An advantage of the last two is I have better control of the tissues. So I'm going to choose the one I'm more comfortable with, and that's going to be forced eruption. And that is because of the fact that it provides predictive vertical augmentation while at the same time preserving the soft tissue architecture. So this is what happens in the mechanics. You guys that do ortho know it well. When you rub this much, you're going to get the roots coming out eventually towards the buccal. Luckily, we have the auxiliaries that we can use for this to just torque everything in. But tell me exactly what kind of bone do you think? I'm getting the vertical height that I need. What kind of bone do you think I have on the labial? Okay, so again, hopeless teeth are not useless teeth. Okay, so now this is what I have. And this is a post-orthodontic splint. Because these teeth were so mobile, I was prepared to provisionalize. But you couldn't put a burr to them. Because if the burr touches them, you basically just pull them out of the tissue. So this is not a temp. Well, it is a temp, but it's a splint built in the mouth. I'm going to ask you for some latitude here. Okay? I'm with it, but. So we can see what happens now after 3 months. Okay? And you definitely see some things happening. Okay, and these are basically the results now from the forced eruption. You can see before and after. I'm outlining on the far side the root tip. Okay, it's in the soft tissue. So it's giving us everything it had to give. Okay, so then the issue here is I had the vertical component. I don't have the three-dimensional volume. Okay, how do I develop the horizontal? Who here will raise a flap? You tell me. This is a legal case, buddy, and you have nothing to do with it. It's not because of that. I just don't want my case to end up like the previous results. You think I'm going to raise a flap here? You see the cleft is still present. I brought the cleft down in the pontic area. I'm not raising a flap. And I'm going to remind you once again what the literature says with respect to raising flaps and with respect to horizontal augmentations. Okay? So, do traditional GBR techniques, are they going to work in this case? And again, the literature is pointing more and more towards the direction that is not the way to go. So I want to introduce something here, and I'm going to ask all of you to be open-minded, okay? And this is going to be completely opposite to everything you've been hearing from all my good friends. And this is the first time the official introduction is at AO, but I think I owe it to these guys being basically in the family environment that I wanted to just show this for the first time. This is what I'm calling it. And there's a lot, but this actually has some meaning, okay? And the meaning of this is basically stands for subperiosteal, minimally invasive, aesthetic ridge augmentation technique. And as a disclosure, I own intellectual rights to this and trademark rights to it as well. So the reason why I developed this was actually in seeking a clinical response to all these challenges. What do you do with this patient, for example? Look at him. Look at the smile line. What if he tells you now, by the way, I'm getting married in 8 months? You're going to take that tooth? You're going to flap? You're going to give him a flipper? Not an approach that we will follow. Also, look at the high risk. There's an adjacent implant already restored. So our approach has been, and this was how it started, was to basically just use a laparoscopic approach where remote incision is made. We have some specially designed instruments that we use to create then access into a pouch. The pouch is created, then we basically use, again, a xenograft material combined with a growth factor, and the bone graft is subsequently condensed, adapted, small incision needs a few sutures. That's it. There's no flap elevated, there's no decortication or marrow penetration, there's no tenting screws or membranes. I'm going to show you the results. So I have the alveolar height, I want horizontal volume, and I want preservation of the soft tissue architecture, right? This is before and after. She had ortho. And you see that in the pre-op here, there's some roots that basically have very little or no buccal plate. So I said to her, I'm doing this for you anyway, I'm going to place some more bone. This is not the first case you should be doing. But let's take a look at it. Let's see the cross sections now. So here it is. I'm using also the international numbers because I know we have a fair amount of people that came from abroad. You see every side, canine, lateral, which is a pontic side, and central. And there is a result. Now I set up not only, by the way, you see how much I have where the apex is, okay, on the central. What do you think happens if I raise a flap? I lose that. And I keep my patients in fix throughout. I make every effort to keep my patients in fix through a treatment. Now, after I develop the three-dimensional volume needed, this turns into an immediate placement, an immediate provisional, in basically sites that are now not compromised. They've been developed to be ideal, and the results are what you see on the screen. So we have an abundance of bone. And this is the arch now with the implants placed. So here it is. This is the canine side, the central side. She's in medical school now. So now it's her schedule that's busier than mine. So this is where she's at. Now she's bleaching her teeth. I'm going to see in the summer to complete this. We're ready to go. But take a look at the soft tissue profiles. Now, Nevins have published this before. And the results that you see there were inconsistent. Some implants were lost. One of the groups they couldn't even be implanted, what have you. We are submitting this for publication, and it's actually been accepted to actually come out in March, April. And you see we have 60 treated sites, 21 patients, 5 treatment categories. These are our treatment categories. So we have from horizontal augmentations to basically augmentation on teeth that are still present to even on implants with exposed threads. So it has allowed me to do things with a lot less risk and more predictability than I could do before. And I'll tell you that in my practice, this is about 90% of the grafts I do right now. 60 sites were when the paper was submitted, which is last year. Now it's over 100 sites. So in this case, for example, look at the concavities. Look at the tissue. One incision, small incision. Now, is there more bone than you need? Yeah, it is, but I'm developing it. I'm testing how far we can go. Look at the soft tissue changes. She's temporized, but I just did it before I flew in here, so I don't have the photograph with me. And now, another advantage is that in most of these cases, because you have so much bone, you can go flapless, guided or not guided. These are not guided. You have plenty of bone. And this is now with the implants placed. We have biopsies. And the biopsies are showing, Julie was talking about percentage of bone. We're showing about 52% of bone. So I think that I can go without actually giving you an idea of what the biological rationale for this also, because it's not traditional. So if you actually start looking beyond traditional GBR principles, which are 20 years old or something like that, you see that there are other things that you need to consider, such as wound stability and space maintenance. Okay? So the fact that growth factor mediated bone regeneration is different, and there's plenty of literature that shows that it may not need a membrane. And also that the periosteum is actually a source for progenitor and stem cells for tissue engineering. That's how this works. How will you do this one? How many procedures? What if I tell you this is just one shot? Here's the implant. Flapless as well. So this is an example of the numbers of all previous publications. This is what we're coming at as our average for horizontal augmentation. I did all the measurements myself. And I tried to be really tight with them because I knew the number was exceeding others. So the publication doesn't include vertical, but look at the vertical. The patient benefits are clear, okay, in terms of less swelling, less discomfort, less possibility of complications as well. And I just want to ask you to be a little bit open-minded with this, because clearly it goes in a different direction than what you've been presented with so far. I want to now conclude with basically just a few remarks. Clearly, well, at least in my opinion, in the aesthetic zone, preservation is more predictable than regeneration. The most predictable implant aesthetics we basically achieve with immediate implant placement and provisionalization in ideal sites. The surgical techniques, traditional surgical techniques, are not predictable, particularly with regards to the perimplant soft tissue contours. You can get bone, but the tissue is the issue, as David always said. And finally, interdisciplinary tools are what you need to utilize when you have these complex cases. And the minimally invasive surgery is part of that. You get results that are comparable or better than traditional techniques, with no membranes, no tenting screws, less pain and discomfort for the patient. Eddie asked me, he thought it would be not a bad idea we're just getting this started. We're gonna hold this first certification course in June. Again, we're hoping to be doing some work with you guys as well. This may signify a change in careers for me, but it's something I feel has the potential to change the field, pretty much like angioplasties have changed open heart surgery. Do you need open heart surgery? Some patients do, but it's not all of them. I would argue it's a minority of them now. So with that, I want to thank you for the kind invitation and for the attention as well, and I'm very grateful to you guys. Thank you so much.
You just saw a world premiere. Absolutely told us that he had something very, very unique to show you, and you're the first group, I believe. This is it, right? First time. Don't tell anybody. It's top secret. You only tell them, hey, you only learn it here at Dental XP, these kinds of things. But you're going to continue to see some outstanding material presented. And I want to thank again Ernesto for just really bringing us a wonderful presentation. I'm very curious to see exactly how you do that. I think all of us are. With the philosophy behind Dental XP being always to look for talented people are everywhere around the world, and we really try to embrace that. And we've had some people that you may not have seen before on the podium during this meeting. Attila yesterday with a beautiful presentation, Neil today.